streams, most specifically aimed at preventing people, giving people other opportunities rather than coming in to the ED department, supporting our acute model, improving flow and improving discharge. We are working in partnership with local authorities and with our comms. One of the things we are very much promoting, and it will come into the COVID piece, is obviously vaccination, given the upturn in COVID, and you won't have been able to ignore that across the media, but also the risks that we're acutely aware of in terms of potential for a flu upsurge. Okay, so the slides outline the progress that we've made to date on the improvement programme. It is a whole system improvement programme, but it is actually broadly broken down into our east, west and centre areas, so that the areas and the acutes are working, and primary care are working collectively to deliver the improvements that are going to make the best benefit for their part of the system, whilst we're using a consistent methodology. We are supported in this by Welsh Government, and we do have Ruth Accolado, who some of you may or may not be aware of, who is a physician, consultant physician, who's working with Welsh Government, who is supporting us in this programme as well. So that's really positive, because she has given us that confirm and challenge. I won't go through all the updates. You have them before you. I'm more than happy to take questions on those. And this morning, the teams have been involved in an all Wales seminar about what opportunities we can potentially steal shamelessly from other parts of the Welsh system to support primary care. We have got some Pathfinder initiatives in place, but it's what we can learn from other parts of the system. So we do have a combination of operational and transformational actions. We have got some support to further develop what we call our same-day emergency care facility, which will allow GPs to have access to advice and direct access to a facility which will have senior clinician triage at the front door, with the aim of turning those, I don't like using this term, so let me rephrase it, ensuring that patients are seen in a very timely way and have a plan of care which has been signed off by a senior clinician. And that's what you'll see in the paper is referred to as SDEC. Okay, so we are developing those so that we have in place a emergency floor model rather than relying on the emergency department. We're working very closely with WAST, and one of the things that we're keen, and it would be good to have some input from yourselves, is refreshing and revising our directory of services. So what options are available, not just for our GPs and our health professionals and WAST colleagues, but ensuring that people are completely aware and communicated what the options are available to them. We are really keen to work with WAST in three particular areas, the most significant of these being falls. I'm sure that is an area that you're acutely aware of, where we are seeing people with we're seeing an increasing number of falls being brought to our emergency departments, which then may or may not result in people being admitted, and then we will then get into a position where we're rehabilitating these patients, where ideally we need to support them in their own homes. So we're really keen to take forward some work with WAST colleagues. We've done this previously with Welsh Ambulance colleagues, and we've done it with fire colleagues in the past. But what we can do with our third sector colleagues as well, to support people in their own homes, so that we can, if they are falls without injury, only that we support them at that point in time, but we provide the support services to prevent that happening again, because these, I'm sure you're aware of, are people that are vulnerable. They are not priorities for the ambulance service. I'm really acutely aware that they can wait an awful long time for an ambulance to arrive, which is not where we would wish them to be. So we're acutely aware that Bronwyn, or whoever it may be, is not getting a good experience, and their confidence is being knocked at the same time. So that is a key piece of work we want to take forward. So we are working, as I say, with joint work with local authorities around step down capacity, the trusted assessor process on an all North Wales basis rather than a locality basis, and also cognizant of what we can do on a joint workforce. And there's work being done on an all Wales basis, but how we can support them, particularly in the domiciliary care model, because that is causing delays in our discharge. And we're acutely aware that keeping them in our beds is not the best place for them. Our winter plans are being developed and they are being finalised, and they will be in line with the Welsh Government advice that we are receiving. So, and we're quite happy to share those with you. They will be subject to board approval. I am happy to take any questions you may have. I think the point I would make is re-emphasise that the real need, and I know that you guys will be supporting on this, the messages around the need for that COVID vaccination, those boosters, particularly in our most elderly or older population, but also ensuring that people access the flu vaccination, because that is an area that we really are quite concerned about the numbers that we might see. Happy to take any questions. Conscious I've thrown quite a lot at you there, so apologies.
Thanks very much, Jill. I've got a couple of very quick questions. The first one is how difficult the difficulties around accessing GPs. How does this affect your plan?
So we are working really closely with our GPs. I'm conscious Chris isn't here right now, and what they are seeing a significant they are using their virtual appointment systems to access a number of patients. We are also working with the 111 service and the PsyCat services, and it goes back to the directory of services, so that when people do access the 111, we can put them to the right place. And that may be a GP, it equally may be a nurse or a therapist, it may equally be a service that we don't ourselves provide. So we're really, really keen that that has to be developed. I think the big issue that we have is workforce across the piece, and that's both in social care, primary care, but also in our acute facilities.
Thanks, Jill. My second question before I open it up is around care homes and the effect that care home closures is having on your availability for discharge. And is this going to be, it will probably get worse throughout the winter. And as the COVID cases are on the increase, more homes are closing. And there is a shortage of care and nursing home staff, which again will impact throughout the winter. Are you able to compensate, or are you taking this into account when you look at your measures?
Absolutely taking it into account. And one of the things I should say is that we are looking what additional capacity we can put in place and what the skill mix is that we need to support that. But absolutely we are. One of the things we have done as part of our vaccination programme is obviously prioritise those care homes, and I think we're practically at the end of those care homes in terms of ensuring that they are vaccinating. We are monitoring those with our local authority colleagues to see what is the art of the possible in terms of risk assessing the discharges into those care homes. What we are seeing is some of that relates to staff, and because they're already short of staff, if someone goes off sick with COVID, that's the difference between the care home being open or closed. So yes, we are working alongside them, seeing what we can do to support them, but equally looking at other opportunities, including what we can potentially commission in our own right to support discharge of patients.
Thanks, Jill. Stella, you've got your hand up, and then I think Lucy, you want to come in. So Stella.
Hi, Jill. Stella Howard from Flintshire Local Community Health Council. I just wanted to ask you about the high demand on, about the reduction in direct GP admissions to assessment units. Now, my understanding is that the GP phones the bed managers first to see where the beds are available. And I know this has happened on 2 occasions, and, you know, personally, we were sent straight to A&E to go to the medical units instead of being directly, you know, sent to the medical units. So the bed manager must have informed the GP of this. So, and there must be an easier way around it.
So thank you for the question. You're absolutely right. So the principles that the same-day emergency care units are establishing is that the people won't go into the ED, they will go directly into the assessment unit. So they'll bypass the emergency department. Providing, so if the GP is referring in and conversation has taken place, they will go direct. We are acute, as I would like to reiterate, one of the, as you know, we've stopped the vast majority of our elective surgery because of the unscheduled care pressures. So our flexibility around beds has included some of those assessment areas having longer term patients in those beds. So the work that we are doing as part of the improvement plan is to support that direct admission that you quite rightly pointed out. It's the right thing to do. They've already been assessed by a GP. That GP now needs some specialist support. So that's the piece of work that we're focusing on. And we've got a number of clinicians across North Wales and some support now from Welsh Government to further develop that model.
Have you got any idea how long that would possibly take?
More than happy to have CHC input into that development of that model, if that's something we could discuss outside, and then bring it along with us. It will be different in different areas, and part of it, the sticking point will be recruitment. So I alluded to in the earlier part of the presentation that we've now got a recruitment plan and we're recruiting against that. That includes not only consultant physicians and ED doctors, it includes advanced practitioners and consultant nurses. So, and we have been successful to some of those points, but if I'm going to be honest, that is going to be our limiting factor in terms of how fast we can go at this.
Thank you, Jill. Thank you.
Thanks, Ella. Thanks, Jill. Lucy, did you want to come in? No? Liz, do you want to come in?
Yes, I wanted to ask a question about longer term plans, because it struck me that increasingly GPs have been de-skilled in the amount and variety of work that they're able to carry out. And I'm wondering if that slightly puts them off from becoming GPs. I know that a lot of work these days requires access to diagnostic, CT scanners and that sort of thing. I wondered why longer term, maybe there needs to be an increase in more community-based things like some of the minor ops that GPs could do instead of just being deflected to, you know, the emergency department.
So again, I'm not sure if Nick's on the call, I'm sure he'll have some comments, but just to answer that, so the work that we are doing on our diagnostic treatment centre model is exactly to address that, so we can get easier access and direct access to diagnostics from GPs, that we not just do relieve the pressure on our acute services, so we can move some of the activity out of the acute hospitals into those treatment centres, also allow day case procedures and orthopaedic procedures to be done off-site. So it is included in that to ensure that we can move as much activity away from the acute sites into somewhere that is protected out with, and that's learning from COVID. Added to that, one of the things I'm really keen to explore is what we can do using different models of care to give patients direct access to some of those services.
Okay, thank you.
Thanks. Sue Green?
Thanks, Jackie. I think, so just taking the other part of that question, very much around de-skilling of GPs or relevant practitioners in GP surgeries, that's something that we are really alive to, not just in terms of the de-skilling, but how do we attract and retain really good clinical practitioners in general practice. We've done a lot of work, and Dr. Chris Stockport has done a lot of work previously. We've just been working on how do we expand and make it more multi-professional in terms of the GP Academy. So very much looking at how do we develop our general practitioners for the future, as well as clearly linking into the conversations around the medical and health sciences school. But we're also having really helpful discussions, and have started a piece of work around kind of that portfolio piece, as well as skill mix, an appropriate skill mix in general practice, to make sure that we can address as many of the needs of the local population as possible, but also recognizing that and as we've all done a lot of over the last however many months, sitting going through consultations day in, day out, is definitely impacting on our ability to retain general practitioners across the organisation and across North Wales. Very much looking at that kind of portfolio career, which is much more focused as well on teaching, on research, as well as practicing in different physical settings. So having general practitioners practicing in different physical settings, including but absolutely not limited to the acute setting. So there's a lot of work going on, very much to try and build a more sustainable workforce and resource moving forward. I just want to add that in.
Thank you, Sue. Dr. Lyons, do you want to come in?
Well, I have to, don't I, as a GP, with that discussion going on. So I suppose that the GP remains in many ways the backbone with the primary care team as to where medical care is delivered. The vast majority of healthcare is delivered in a primary care setting. So absolutely, to underline what Sue and Jill have said, I think GPs are the maestros of pattern recognition and dealing with health early. But and I think the younger GPs, I spoke to one who was quite inspiring early this week, really up to playing their part and playing it in a different way, using phone, using video, in order to do that. But I think we are, as Sue has rightly said, also offering opportunities. So talking to GPs in West Wales about doing opportunities with Mountain Rescue in order to develop that kind of rural medicine thing, and GPs working in our ED. So we have a combination of the primary care holistic view with that much more acute and arguably exciting, in some people's view, general hospital view. So I think there's a huge opportunity for change, and it's quite exciting.
Thank you very much. Jill, thank you so much for your presentation. I appreciate how difficult you must find it. There's a lot of stress for the ambulance service, your frontline staff, and I know you've already got a tired workforce because they've had 2 years now of real stress and strain, and You're working in extreme difficulties. We know you'll do your best for us, and I'm going to leave it there. But thank you. And if you could pass on the CH thanks to the front line and all the staff that we know are tired, it would be appreciated.
Jackie, they would really, really appreciate that. So thank you for passing those on. As I say, we will continue to consider what opportunities we have, and as I say, engagement with yourselves enables us to test how those are going to work, but also be received by communities. So again, I do want to hold out my hand and offer the opportunities if people do want to get involved in these pieces of work, because it is important that we get people understanding what we're trying to do and get that check and challenge.
Don't worry, Joe, we'll bite your hand off. Before we go on to the next item, Finos, is it possible as the host that you could perhaps share the presentation on the screen? Finos?
So
I think it's Kate.
No, she's handed it over to Finos, I think. Kate, are you hosting or Finos?
Jackie, I'll ring Klinos now.
Hello, hi, it's Finos.
Hi, Finos.
Unfortunately, we're having dreadful IT problems, and I'm not hosting the meeting anymore, but Kate can't see her screen to transfer host rights over to me. I'm just letting everybody know now.
Okay,
we'll just have to bear with it.
Yeah,
no
we'll
problem.
carry on, Finos. Don't
Apologies
worry.
for this. We are live on YouTube, though.
That's
Excellent.
fine. Thank you.
you.
Right, Jill, unfortunately, I think it's back, well, not unfortunately, but unfortunately for you, we're back over to you to do the COVID-19 update.
And you know that comment about nightmares with IT? My IBABS has just taken this opportunity to say update.
Yeah, there's a huge update program for all NHS devices at the minute. Mine spent over an hour updating it just before the meeting. Can we move on to another item, Chair?
I'm happy. I've got it in front of me now. I've managed to do it by a different route.
Thanks, Jill.
Okay, sorry. I can't believe it when it does that. It's just so irritating, isn't it? But so I'll take you through the presentation, and I do want to reiterate it's still very much with us, and we are still applying our social distancing and our mitigations in terms of the work that we are doing within our hospitals, but nonetheless we are seeing community levels levels that we would wish to see quite a bit lower, and you can see that from the first slide with graphs on. So can you, I'm trying to help you with the presentation, the one with the red lines. What you will also see is the confirmed cases on the next slide, and what you can see is some of that is being driven by the local population, the younger population. Quite a number of that is, and now reaching out to support immunisation of that younger population group is critically important to us. Hospital inpatients, again, you'll see that those numbers are not dropping. In fact, we are seeing slight upturns across all of our sites, with the exception of East, but that is really just in a plateau scenario. We are also seeing numbers in our critical care units, stretching our critical care units in a way that we haven't seen for quite some time. So we are monitoring that quite closely. That is impacting not only our capacity within our within our critical care units, but inevitably has again an impact on our ability to deliver services as we redistribute anaesthetic colleagues to support critical care, both in the respiratory units, but also in HDUs and critical care units. So that has an impact across the board. So what I would say very much hasn't gone away. I am going to ask, I'm assuming Teresa is on the call. Sorry, I can't see all the participants.
Yes, she is, Jo.
Yeah, I'm here.
So, Teresa, would you mind picking up the test and traced? I hand over the baton.
Thank you very much, Jill. Yes, of course. Pam da pawb. Firstly, then on testing as per the slide, do you know we've had some of the highest volumes right through the whole pandemic most recently. Thankfully, we're seeing a little bit of steadying in numbers in terms of people being tested, but I have to thank the population for going to be tested and following the guidance. Colleagues have been great. We've had higher volumes of testing across North Wales as well than we've had previously. We've got a significant amount of testing slots still available in North Wales. There's about 35,000 tests available here now. Of course, COVID phases change and there may be a change in testing requirements going forward, but at the moment we're well placed on testing activity. As Jill's already mentioned, the majority of those cases are in younger people, but I think we're starting to see some of that transmission potentially within homes back into families and the older people. And of course, there's that live discussion in terms of vaccination being most important, but the vaccination potentially waning over a period of time. So if I move on to tracing then, I have to say that we've had a huge number of index cases and contacts across North Wales. We continue to have a strong TTP partnership function across North Wales. It's only thanks to our local teams and local authorities that much of that tracing happens, but we also have a regional hub where some of the specialist arenas are discussed, including hospital tracing. To give you an indication of the numbers, I think it's in your slide, over 3,000 in the previous 7 days, and we have contacts about 8,000, and that reflects level 0, where people are just mixing and mingling, and hopefully with mask wearing and hopefully still washing their hands. Those messages, as Jill has said, are as live as ever. And then if I look to Protect here in North Wales, I'm glad to say that our 6th COVID hub has just opened in Conwy area, thanks to a partnership with the Conwy Voluntary Council. My thanks to them for their support. And each of the 6 hubs, one in each local authority now, has been a different partnership arrangement, but the offer is very much similar in each. So whether it's around the LFD devices, which is where this started to enable people to work, especially when they had to go into work rather than work from home, food poverty, and are also around credit support. It is a model which has received a lot of attention across Wales, and I know that there's a real push to try and get similar models across the rest of Wales. For me, we are evaluating the impact and the urban rural aspects of that. And then I won't dwell on the risks too much today, but as you can imagine, recruitment is probably one of our biggest risks, if I'm really frank with everyone. I'm not alone there. I know all my colleagues in the health board would say similar things. This is a partnership arena, and the good news is that the index contact tracing and contact tracing in general, we have now had an update that will continue until June 22. That hopefully will help us retain some of our workers in terms of test, trace and protect. Thank you, Jill. I'll stop there.
Thank you, Teresa. And I just want to re-emphasise that all this additional work that's being done by the teams is another workforce resource that we're pulling on. There are hands up. I don't know whether you want me to continue, and we take questions at the end, Jackie. It's entirely up to you.
I think we're better going through the presentation, Jill.
Okay, I just wanted to clarify.
Yeah, thank you.
So in terms of vaccinations, it does continue to be a positive story across North Wales, and you'll see the numbers. As of 11th of October, we'd given well over 1 million vaccines, somewhere well over 44,000 of booster vaccinations, and we have focused, as I said earlier, on staff, those older age groups, but most specifically around our care homes and social care support as well. What the next slide will identify where we're up to against all of the initial cohorts, and clearly what isn't demonstrated on there but is demonstrated by the 44,000 is the fact that we are well on the way with that third booster jab. And it comes back to the point that Teresa was saying earlier about the waning, potential waning of the effectiveness of the vaccine. It's probably, so coming on to the next slide, we have, as I say, commenced the booster programme. We are booking appointments in for the 12 to 15-year-olds with underlying health conditions, and we are now well and truly booking in those 12 to 15-year-olds without underlying conditions. I think the other point to make is we're currently doing the plans of how this is going to work for the future, and that includes how we're going to deliver the vaccines. As you know, we've been working with local authority partners and other partners in terms of how we do deliver this vaccine via mass vaccination centres, local vaccination centres, and indeed pop-up vaccination centres. If the efficacy or the effectiveness of the vaccine is going to be 6 months, and we're going to have to do a follow-up booster, we're already considering our plans of how we're going to continue to do that and maintain that on an ongoing basis. Clearly as well, that will depend on the type of vaccine, any modifications of the vaccine, because I am fairly sure that there is work going on in the background to obviously improve on those vaccines that we've got available to us, and certainly the administration. We are giving our primary care clinicians, we are giving the message that where we are able to, the flu vaccination is being given at the same time as the COVID vaccine. However, that's not always possible given the way that we store and manage the Pfizer vaccine. Again, happy to take any questions on that. I think we refer to the coronavirus control plan in the slides and managing the impact of COVID-19. I do want to reiterate this is now, we're now in a resilience phase, and I want to overlay the fact that we are expecting high levels of flu. The measures that we put in place to protect the population from COVID has reduced immunity. So we are conscious both of respiratory viruses, both in the children and in the older, across the population ages, but also other viruses that are likely to impact the health service and social care system over the next few months as we head into winter. So our plans are considering all of the above. Happy to take questions. I can see Jo may want to add something to that, because I know she's got a hand up, and Jackie, you're chairing, so apologies.
Thanks, Jill. Your presentation was most welcome. I'm going to call on them as they've put their hand up, Jill. So I'm going to go to Councillor Cheryl Carlisle first, please.
Thank you very much, Chair. Thanks for that. And thanks again, Jill and Teresa, for the presentation and obviously all the amazing work that's going on in the background. Mine's just a quick question around the vaccinations. The JCVI cohorts slide shows the 12 to 17-year-olds. We've got 62% for the first dose, only 4% shown for the second dose. My question was around the offer to the 12 to 15-year-olds. I can see the appointments have started since 4th of October, but given the prevalence in that age group, how many have been offered so far, do we know, across North Wales? Where are we with the offer to the 12 to 15-year-olds, and what's the take-up like? I know you won't have the precise facts at your fingertips, but general. Thank you very much.
I think Jo may have the answer to that question. I can see her waving in the background.
Just to say that one of the challenges, Cheryl, that we are facing at the moment is community prevalence in that precise age group. And because you can't offer the COVID jab if someone has most recently had COVID, that is driving some of our challenges around take-up, DNA rates, and indeed take-up over time, because we just have to wait. And there's nothing we can do about that in order to be able to offer those jabs. So that is significantly impacting on those that uptake. I don't have the precise numbers to hand, but I do understand that's one of the drivers around the higher do not attend rates. We're also just picking up on. Colleagues will remember when we went through the first flu vaccination program, we were offering online bookings and things like that. So I have, working with Jill, asked the team to look at whether we can reintroduce online booking, and just being mindful of some of the public transport challenges to some of the local vaccination centres. There's obviously a trade-off between asking people to drive to one of the mass vaccination centres or going more locally, but we are aware for some of the vaccination centres, particularly those in central, we do need to think about transport, because they're great if you've got a car location wise, and not so good if you're on public transport. We've also had feedback around older people queuing in the dark, or not being happy to drive in the dark, and where practices are interested in delivering the vaccination themselves within the practice, we're also trying to facilitate that where possible, though that is limited because of the use of Pfizer for booster jabs. So although our primary care colleagues were super supportive during the first vaccination process and would like to be helpful now, there are a few more limitations around us with this particular phase. Thank you. Back to Jill.
Thanks, Jo. Thanks, Jo. You've picked up a couple of points I was going to make. I think the primary care, there is a big balance here as well, because we alluded to it on the unscheduled care, that we need people to be able to access their GP for unscheduled care. So there is a fine balance here, but they have been incredibly supportive. But I would also reiterate that the ongoing conversations, if I take D-side, for example, our local authority have been very, very supportive in allowing us to maintain that on an ongoing basis as a vaccination centre. But these are the things that we're going to have to explore going forward. So just to add that.
Thanks, Jill. Mark has just put something up in the chat about receiving a number of concerns about signage, transport, logistic, wait times, as Jill referred to. And Mark has asked for a wider brief to be prepared for the board members on the concerns, responses and delivery progress. So thanks for that, Mark. Frank,
we're happy to share that with you, because I know that we were pulling that together. The other point is the refreshing of the communication plan that sits underneath it.
Thanks, Jill. Frank, you've got a question?
Yeah, it's around, you've just been touched on it a little bit about where doctors, surgeries, GPs are unable to give the COVID jabs. I live in an area in Chirk where our doctors are unable to do it, and I fully understand that. I wouldn't argue with their decisions, but I think there's got to be, a method of getting people who have those transport difficulties into, and from here at the moment it's going into Wrexham, which is for some people quite a jaunt on a service bus, you know. So what sort of thoughts have you got on making that easier for those people that are in that vulnerable age bracket and need that definitely certainly need that booster jab anyway? And just one final comment really, and it was something that pointed out to me. A friend went for his booster jab in Wrexham a couple of weeks ago, 12 o'clock appointment, and they asked the person in front, what time's your appointment? And this lady said 3 o'clock. So, you know, that's one of the issues, that people aren't respecting what you're doing by setting appointment times. So, you know, I think you need to emphasize if 12 o'clock appointment is a 12 o'clock and a 3 o'clock to 3 o'clock. Thanks.
So thank you for that feedback. I will take it back. I know that we have challenged people and we're calling them in by appointment time, but that, you know, I just ensure that that is happening consistently, because you are absolutely right. I think the other point in terms of those people that are most vulnerable is we are working to get to them as well. So previously we've used district nursing teams, local pharmacists, etc. It was much easier when we weren't using the Pfizer jab. But what we are doing is working with our pharmacy colleagues and packing it down in smaller numbers so we can transport, and that's where we have had some success. Hence the principle about what can we do about pop-ups and mobiles. So we're continuing to explore that, and it will be part of the brief that Mark's alluded to in the sidebar.
Thanks, Jill. Thank you very, very much for that. Before we go on to the next presentation, Linos, could I ask if you could put the presentation slides on your website so that the YouTube viewers can pick them up?
Yeah, Louise, I think we can look at that, can't we?
Thanks, Linos. I'll leave that with you.
All right, thank you, Jackie.
Thank you. Now it's over to the chair, Mark Collins. Mark, you're going to give us an update on the board membership.
Thanks, Jackie. I'll be succinct, given time. So key changes to note as far as the health board membership is concerned are the arrival of Nick Lyons, the new executive medical director, and you've heard from him already. The joining of the board by Claire Budden, who's on this meeting, who's taken over chair of the stakeholder reference group and brings a lot of relevant experience to the board. And then a few weeks back, Jackie, we held a selection process with Welsh Government for 3 new members to join the board, 1 a community rep, 1 a finance rep, and the third a third sector rep. Now, I can tell you and your colleagues that we were successful in making selections. I just can't tell you who they are quite at this moment, because we're trying to clear the appointments with Welsh Government. We also selected a 4th member, Jack, as a standby community member moving forward. So as soon as I am able to do so, I'll let you colleagues know the identity of the 3 new members. And I would anticipate 2 of them will start relatively immediately. The 3rd will follow a little while later. But in terms of what otherwise might have been a gap in the delay of the 3rd person, it's been mitigated by the fact that Lynn, who's one of our, of course, experienced and best members who's on this call too, will be covering the gap for us. So I do appreciate Lynn being flexible in that regard. So that's what's happening as far as the board membership is concerned, Jackie.
Thanks very much for that, Mark. Appreciate your time. I know you're a busy man today. We're going to take a 5-minute, 10-minute break now and come back at just turned 3 o'clock. But don't forget to pick up the chat bar, because members are putting comments on the chat bar which are quite relevant to what's been said today. So see everybody in 10 minutes time, just before 3:05. Thank you.
can see that.
Yeah, yeah, that's clear. Thanks, Sue.
The meeting's still being streamed.
Thank you, Kate.
I don't know if everybody's back. Our next presentation is, hi Joe. Our next presentation by Claire Darlington. Claire, are you with us?
Jackie, if Claire isn't, I'm happy to go through the presentation. Just give me 2 minutes and I'll grab it on my screen. Hang on.
Yeah, we're finding that our NHS net computers are going, are dropping themselves into update mode almost at random. So maybe Claire has been affected by that.
Quite possibly. Thank you very much for the opportunity to talk about our Living Healthier, Staying Well refresh, or our Living Healthier, Staying Well update. You will all recall that in 2018 we published the Health Board's long-term strategic plan, Living Healthier, Staying Well, just before the publication of a Healthier Wales, Welsh Government's own approach, and of course before the advent of the COVID pandemic. It's a good time for us to think about a refresh of our overall strategic framework, because it gives us the opportunity to check in with our patients, partners and staff that our principles are still valid. And those principles around care closer to home, around integration, around working hard on population health and prevention still feel like they've stood the test of time to me. But it's important, given our COVID experiences and the learning associated with our Healthier Wales, that we check that out with all of us. And we also look to those aspects of the elements of Living Healthier, Staying Well that have proved challenging for us to implement, as well as acknowledging that we have made some great successes in terms of implementing, for example, joint working across health and social care, which was one of our Living Healthier, Staying Well principles, with feedback already being received from some of our partners that work now needs to move into much less about co-locating teams and teams working together, much more into trusted assessor models and genuinely thinking about patient-centred care. These principles are important to us. A strategic framework is important to us because it helps us frame the conversation that we will talk about next in terms of our clinical strategy update. And because it helps us make sure that as we move into our more tactical and operational planning in terms of delivery, we use these principles to help us prioritise our choices by way of planning priorities. And we want to test out that the strategy still feels right, given the learning that we've been having around service delivery in the pandemic. Vaccinating pretty much the population of North Wales twice and then a third time has provided us with an opportunity to think, for example, very differently about how we undertake vaccination programmes. And we already know, for example, looking at the absolutely fantastic virtual joint school, which is an online orthopaedic pre-joint surgery assessment process, there are some real innovations that we have delivered and developed on the back of COVID that we want to see whether we should stay with those. Because we're looking at a refresh of our existing strategy, we are taking an approach of a light touch engagement process, and we're thinking about our main analysis of our main themes to see what our feedback might be, using discussion documents, leaflets, information in easy read and BSL, and a widely promoted and widely shared public survey, which is online, and hard copies are also available. Using Living Healthier, Staying Well web pages, social media campaign and so on to extend and remove language barriers. And as part of our whole scale staff engagement, our discovery phase associated with a piece of work that we call Living Healthier, Staying Well, we have engaged quite comprehensively with our own workforce about the principles of living healthier, staying well. Early aspects of feedback do suggest support for our goals, for the principles, but concerns about our capacity to deliver, which is very relevant given Jackie's thoughtful comments about the tiredness of staff and Jill's comments about the potential uptick in COVID numbers. That as an organisation, we know, and we're told we still need to attend to matters of culture, leadership and development, and bringing our 5 organisational values to life, putting patients first, learning and innovating, valuing and respecting each other, working together, and communicating openly and honestly. Issues that will be familiar to colleagues on this call from either the board or CHC are, of course, the ongoing challenges around transport access and rurality that face us in North Wales. A reminder to us all about the importance of prevention, and including and feedback has also included concerns about waiting times for GP appointments and for inpatient and outpatient care, which is a matter that the board is extremely exercised about as well, and have recently made some very positive decisions with regard to additional capacity, with regard to waiting list capacity for some long waiting specialties. And again, something that's very dear to my heart around patient experience. Some of you will know when I speak to staff, I talk about my 6 personal priorities. The first one is patient experience, and that's around communication gaps between primary care and secondary care, across secondary care providers, between teams, and with patients and families, which is something we're seeking to consider as part of the work that we want to do, thinking about the way we work, thinking about our operational model. And aligned with concerns about waiting time are ongoing concerns around access to mental health services, compounded by the burden of disease associated with COVID across the full spectrum of mental health services. So our survey closes at the end of October. We'll share our findings in November, and feedback will then be taken into account into our organisational development and design piece, Stronger Together, as well as into the work that which Nick will introduce in a moment in terms of our clinical services strategy. We'll of course share a draft version with colleagues, with partners, including yourselves, because of course this work will feed into our integrated medium-term plan, which is our operational plan for the next 1 to 3 years, will act as a framework within which we will develop our clinical services strategy, and will help define the working relationship that we have with our partners. We are out and proud about the need for us as an independent statutory organisation to have our own strategic framework, which is incredibly strong on the importance of population health, on the importance of prevention, and on the importance of partnership working. But we absolutely acknowledge we can achieve this work much better in absolute lockstep with our partners. And so whilst we will be seeking partner support for the principles, we're clear that partner support for delivery will be absolutely key. I'm very happy to take questions, and I absolutely acknowledge that this isn't a piece of co-design or early engagement, because as it is a piece of building on a refresh of our existing strategic framework. Jackie, I'm happy to take any questions. Diolch yn fawr iawn.
Thank you very much, John. Thank you for stepping into the breach for Claire. It could possibly be my fault because I did start we were a little bit in front of the times on the agenda, but it's nice sometimes to get in advance. I can't see any hands up at all, Joe, but what I can tell you is that the majority of our community council friends have all had the opportunity in the local meetings to put forward their views to the office. And I know that Carol is busy working away at a response to the survey, and we'll be delivering that for you soon. Well, before the 27th of October anyway. But I think all our members have had the opportunity to feed back into that. So that should be quite good. So all I can do, Joe, is say thank you very much. And I think in this instance, we've had a presentation 3 years ago on living healthier, staying well. And most of our members were around at that time. So I think the questions that they would normally ask were asked at that time, because this is an update and a refresh, as you say, and I think they are conversant with what it contains. So thank you very much for stepping into the breach. I'm going to move on to the next agenda item, which is clinical strategy update from Dr. Nick Lyons, our medical director. So up to you.
Thank you, Jackie. Good afternoon. So what I'm going to do is perhaps outline where I think the clinical strategy fits into the other pieces of work, perhaps then go through what it is and what it is not, and then hopefully a discussion as to how the Health Board can work most effectively with the Community Health Council to take some of this work forward and make sure that it is both effective and authentic. I'm sorry we can't share the presentation on screen. I think we're all having a few IT issues, and we thought we'd sorted it during the coffee break, but the cunning plan failed. But it is on our website, those of you who don't have it in front of you. So if we look at I call it irreverently, the blobogram in the presentation, those who have it, then where does a clinical services plan fit in? So I suppose we have the Healthier Wales, the document that you will all be very familiar with, if I can show it on camera, not very effectively, of the little boy sitting there in the playground, which gives the purpose. And I think we're very fortunate in Wales to have that really well-written, clear document of the purpose that gives us guidance as to where we should be going. And as Joe has outlined, we then managed to summarise and focus that as the goals for the Health Board in living healthier, staying well. So the purpose, Healthier Wales, the goals, living healthier, staying well. The how we do it is the response to Stronger Together, the exercise that's currently going on, which leads potentially to our operating model. But for me, crucially, and what I'm going to talk about, the clinical services strategy, the clinical services plan. What are we actually going to do as a health board? I think it's really important to have that what, because that really then leads on to further work around clinical pathways and helping our clinical teams really focus on their priorities within a clear framework, which perhaps is a little overdue. So it's quite exciting to be leading this piece of work with everybody else. So what is it and what is it not? It's not, and it's a trap we could easily fall into. It's not a strategy for secondary care. And whilst it does make there are some principles there that help us think through the function of our hospitals, it is much more of a focus on outcomes, on population health, and a move of care from our acute hospitals into primary and community care. Recognise the importance of that we had in previous discussions. I think perhaps it's long overdue that we really do, as Healthier Wales challenges us to really think about that population health, so that we're not always thinking about the referral to the specialist hospital of our cancer patients, but instead, what can we do much further up the pathway in primary care to make sure that patients are referred earlier? What can we do working with local authorities and with the third sector to think about what can we do in health promotion to actually prevent disease? It will not be a piece of work that's written by me or the executive team. If it has any authenticity, then it needs to be written with our staff, with our partners, with our population and our carers. A true example of co-design, recognizing it's really easy to do co-design badly and much harder to do it authentically. I'm not going, for those of you who've got the presentation in front of you, read out every line. You'll be relieved to know in the principles, but I will perhaps just highlight a few of them. It does need to be patient-centered. It does, for me, need to be authentic. It does need to focus on prevention and perhaps demedicalizing, declinicalizing healthcare so that we encourage people and support people, importantly, to look after their own health. It needs to be evidence-based. It can't be individuals' ideas, yes, but not ideas that aren't based on evidence and best practice. It needs to be focused on those outcomes, that bigger picture. And crucially also, it's not just making sure that there is a way of delivering healthcare, it's making sure that the healthcare is accessible. It's in the right time and it's the right place. It responds to people's needs, whether that's their difficulties in access, their language, and all the other areas we need to think of. So not easy to do. It needs to be prudent. Public and professionals are equal partners. I may be a GP, but that doesn't mean to say I have a view which is any greater than those of patients I treat or the population we as a health board serve. And we do need to care for those with greatest need first. We need to start to do only what is needed. But that means, of course, stopping doing some stuff which arguably isn't needed. And we need to do no harm. And we all know, I think, that some of our clinical activity does, all the international evidence suggests that actually we do harm in some of the care that we traditionally offer. There are some early design principles there. Crucial, perhaps for me, is the fourth bullet point, is to say there will be 3 acute hospitals in North Wales. Each of those will have an emergency care centre. And of course, if we accept those principles, that means there's a lot of other services in our acute hospitals are given. Because if you have an emergency care centre, if you have an accident and emergency department, as we used to call them when I worked in one, then you also need surgeons, you also need physicians, you also need an X-ray department, you also need to ensure that there's access to paediatric services. But we've got to be really careful, and I need to be really careful, that that fundamental principle of 3 acute hospitals doesn't mean to say that the focus of clinical care, the focus of our clinical strategy is in those hospitals. It's not, it's wrapped around the patient who's a real person who lives in our community. So we need to think how effectively we can deliver care closer to home. We need to think how regional treatment centres fit into this. We need to think how a hub and spoke model and networked models can actually work effectively, recognising that our care needs to be safe, to the highest standard, and that incredibly difficult conversation that all of us have been around. How do you achieve that compromise between having that care close to home, yet at the same time having it as an area in a place where you have specialists who are seeing that volume of care, that they are both competent and confident to deliver that care. Words easily used, but perhaps words sometimes less easily enacted. So it'll be through a co-design. We've already had the first steps, tiny baby steps in doing that, in now 3 mini workshops, sadly all online because of the COVID issues that Jill and Teresa have already described to us. We want to establish a clinical senate function. We may not necessarily call it a clinical senate, but a position, a function where those clinicians, not just doctors, are able to really comment, and not the usual voices, but those frontline clinicians who actually have a lot of wisdom, but we don't always engage with as effectively as we should. As Joe has expertly presented, we also need to fit in with the Living Healthier, Staying Well timetable and the feedback from Stronger Together, in which case I personally start to get a bit of migraine sometimes in how we ensure that we time this and we phase this correctly. And then crucially, how do we involve patients? How do we involve the voluntary sector effectively? And the hope is that the product, assuming that nothing happens this winter that prevents our plans, that we hope we will have a product by the end of this financial year. But that product is not an Encyclopedia Strategica. This is not a 12-volume every pathway in North Wales. This is probably a 12, 15, 16-page document that outlines the principles of how we would deliver care. So I'm very happy to take any questions, but I suppose the last slide in the presentation for those who have it with them is a very genuine question. Is learning from work that you've done, and being new, I haven't walked all of these paths with you, but how can we genuinely work with the Community Health Council in this piece of work? You distill a lot of patients' experiences and patients' views already. How can we work together to bring that experience and those views into this piece of work, and recognizing some of the tight timeframes and the difficulties of phasing the bit of work? Jackie, how can we most effectively work with you? How do you want to be involved? Would love to know, and happy to take any questions. Diolch.
Oh, thanks for that, Dr. Lyons. It's a nice, succinct presentation. And from my point of view, I think continuous engagement with us, openness and transparency is the way forward. And I think that is how we can deliver to you the best experiences as well as the worst experiences, and be ultimately as honest with you as we hope you are with us. And I think that is how we would like to take it forward. And we're here, we can help in any way, we can engage, we can do safe space events, and we can support you to deliver what hopefully the best results for the patients in Wales.
I'd really welcome that. Thank you so much, Jackie.
Has anybody any questions for Dr. Lyons?
Please do call me Nick, Jackie. I must say, I'm only called Dr. Lyons when I've done something wrong. Please, Nick.
Yeah, you see, you're learning already, Dr. Lyons. Thanks very much, Nick. It's much appreciated, and we did enjoy your presentation. Oh, we have a question for you. Liz, do you want to come in?
It's not really a question, it's just an observation that I think one of the main areas for engagement is really working on the communication at all levels within the health board. I think sometimes frontline staff feel that they don't get listened to. That's one of my observations. And I think the communication is the only thing that's going to actually really make things work properly. So that's just an observation.
Thank you, Liz, and a valid one. And I hope through some of the engagement and the listening and conversations around this, we can build some ways of communicating and relationships with some of our staff groups and partners that we can then take those relationships forward in the longer term. Thank you.
I think you got off lightly there, so thank you very much, Nick, for your presentation, and we'll speak to you soon, and we will keep you informed with anything that comes our way that we think might benefit your clinical strategy.
I'm very grateful. Thank you.
Thank you. So the next item on our agenda is urology services update. And I'm afraid, Jill, it's back to you, love. You're working hard today.
I always work hard, Jackie. Okay, and I know, Jackie, I think, in fact, I'm fairly sure you were at the QSE meeting that we held where we discussed concerns around urology services and how we wish to take those forward. So I think it is timely to give this presentation to you here now. So I know that you are well aware and have indeed raised your own concerns about some of the access to our urology services and the consistency of the offer across North Wales, and the concerns that have been raised via yourselves from patients and stakeholders, but also directly to ourselves, and you'll know via the Ombudsman. So really want to pick up what we are taking forward and how we wish to address this. And I know, Jeff, in fact, I've received a copy of an email from yourselves about how we wish to involve yourselves in the improvement journey, and also ensure that we've got clear public and patient representation, so we're calling on that. So an environment to change is needed to address the concerns that I've alluded to. We have successfully now, the tender has been awarded for the robotics programme that will commence in the West in Bangor. And I haven't forgotten, Jackie or Jeff, the invitation once the robot is with us, the invitation for you to see it in situ. So I will ensure that that happens for you both, because I know you've been a long time waiting. It needs to address the investigations and concerns raised from the Ombudsman report, which has now been published. I know we did discuss it at QSE, but clearly it was under embargo at the time. The shortfall that we have both in senior clinical staff, but in the wider clinical workforce, and the impact of an increase in waiting lists, which we are seeing across a number of specialties, but urology is clear of one of those. I think it's also worth saying that this has been a subject of discussion with the board for some significant time, in terms of addressing concerns that have been raised via complaints, direct conversations with both staff and patients. So I think there's an acknowledgement of all of that. It was discussed at QSE. As I say, Jackie, you were in the room, and there was support for a number of actions to take this forward. One of them being a request for an independent review from the Royal College of Surgeons, which is being taken forward. The terms of reference of those will be shared at next QSE. They are being adjusted in line with the college to ensure that we maximise the benefit of that visit. I think at the time of QSE, we acknowledged that the review, the timeliness of the review is likely to be somewhere in the region of 6 months, and that's because has indeed been impacted by COVID, as we know from the vascular work. we felt quite strongly that we didn't want to wait for the outcome of the review, given that we had some of that feedback and we had some actions that needed to be taken as a consequence. So it was further agreed at QSC that there would be an improvement group. That would be chaired by myself. There would be a clinician representative, public representation, and we've reached out to yourselves, as we've alluded to ensure that this is a transparent process. It will also include oversight of the implementation of the robotic services in Bangor. So again, that we've got full visibility of how that is being implemented and the impact of that on our patients and public across North Wales. We also acknowledge that there's work to do around getting it right first time, getting it consistently right first time across North Wales for urology services in terms of access to service, the way we deliver service, and ensuring that we've got consistency around our multidisciplinary team and cancer working. So that has been acknowledged, and we're working with the Getting It Right First Time team, which does involve expert clinicians, and we're anticipating that they will be working with us from November. And again, that piece of work will be overseen by the improvement group. We've already taken action, and Nick and Sue, Nick Lyons and Sue Green, and myself been working closely to establish the gaps in the workforce and ensure that we are responding to that in a timely way. And we do already have some, we're already recruiting against senior clinical staff. We've done some work to assess where those gaps are, and indeed we've taken a decision to increase the number of consultants in relation to that demand. And you'll also be aware of the work that is being undertaken to develop those regional treatment centres. And I know we've had conversations about those, but clearly part of the underpinning principles of those treatment centres to ensure that we get fast access to the right treatment for our patients, and that is consistent and equitable across North Wales. So they are very much part of the conversations around our regional treatment centres, both for diagnostics, but also for some interventions and outpatients. There is included within here some of the goals that we're discussing around the regional treatment centres, and it seems it's all ask of you guys today, because this is another piece of work that we're really keen to co-produce with our populations, so they fully understand and we can maximise the benefits of these. But you can see, and it is part of our pathway for urology, that this is about reviewing the operational and clinical models to ensure that we are maximising efficiencies, but also pulling on the best available evidence and aligning that with the Getting It Right First Time recommendations, but also in the recommendations that come out from the Royal College. I've already alluded to the fact that we'll be working closely to use this as a vehicle to reduce our cancer waiting times and our patients waiting for assessment and diagnostic. I know that is a deeply worrying time when people are waiting for those diagnostics, waiting for those results, and they want to progress those pathways. So for urology, that has been flagged as a concern. It is one of the things that we want to address as part of the regional treatment centre and our improvement plan for urology services. We have got a suggested membership on one of the slides. Again, that has not been fully ratified. We will be discussing that at QSC. I think, Jeff, you've had the reach out to yourselves in terms of, and I know you've demonstrated that, yes, you would want to be involved in that piece of work. But what you can see is we're already working up who should be represented within that group. But also, I think we've scheduled in a date for the first meeting, the 24th. I think it's the 24th of November. That's yet to be finalised, because clearly we want the best representation. So we've got some indicative terms of reference there. Again, they are still at this point indicative. It's trying to pick up the points that were raised within QSC, that were raised as part of the terms of reference for the Royal College review. And we're absolutely cognizant of the fact that any recommendations that come out of that review will be fully embedded within that improvement programme. So it is aligned with the strategy that Nick alluded to. So all of this is very much working towards one direction of travel. So doing this as holistic, working with primary care colleagues as well as secondary care colleagues. And one of the pieces we're working on with our board secretary is ensuring that we've got appropriate governance arrangements in place to support that. I'm happy to take any questions, and Jackie, I know that you were at that meeting, so I didn't know whether there was anything you wish to add.
No, I don't think so, Jill. All I am concerned, well, not concerned, pleased about is the fact that the robot seems a little bit closer tonight. The champagne's been on ice for almost 12 months now, so Jeff and I are looking forward to drinking it.
I'm looking forward to showing you around. I think there's been some blips around the contract. There always is when it's of this magnitude. But Joe, I think you've confirmed that there is going to be a sign off, and we will be updating our Performance, Finance and Integrated Governance Committee on where we're up to against that. But we're ready to receive.
We most certainly are ready to receive. There are just, as Jill says, a few wrinkles to work through in other parts of Wales. Thank you.
I don't mind sharing the champagne with them, Joe, if it quickens the process.
Yeah.
Have we any questions for Jill? Thank you very much for that update, Jill. It was appreciated because, as you know, this is one of the things that has been very close to me. And I think it was ingrained in me by Dr. Christine Evans how vital it was. And I think if I speak to her and I can't give her updates, I get told off quite dramatically. Yeah. So thank you for the updates. And we'll keep you informed, and we look forward to visiting Bangor. No questions at all for Jill. Oh, excellent. So Jill, it's timeline for publication of review of Morva Ward at Llandudno General Hospital.
I can tell you that the report is virtually finalised. In line with the terms of reference of the report, we are ensuring, and the process of ensuring that everyone who has contributed to the report has an opportunity to sign off both their comments but also to receive, and that includes our regional adult safeguarding board. So the timeline for publication, we're endeavouring to get that to our QSC meeting. As I say, it's just subject to ensuring that those individuals have the opportunity to sign that off. What I've also, forgive me, Lucy, for taking your name in vain, but I have had a text conversation with Lucy today. We are keen to get people who have inputted into that report to present back their findings and their immediate recommendations. So we will be reaching out to contributors, including a member of the public who has been really supportive, who you're well aware of, presenting back to QSC alongside the work that our dementia care consultant nurses, who I know you've met with, in terms of the work they're taking forward as a consequence. I'd also like to reiterate that the improvements are not waiting until the review is published. Clearly that would be inappropriate. Our ambition is to improve services immediately we find out what the concerns are and to put those plans in place. So that piece of work in terms of next steps is already taking place.
Thanks, Jill. I think Jeff wants to come in, if that's all right.
Yeah, I'm really pleased with the speed of this process, and with the involvement of the 2 new consultant dementia nurses. I know that this was the first thing they did, coming fresh to the area, and I think the involvement of someone with real experience of the services, a patient, a service user, was really important. And I know that the reviewers felt that as well. So we look forward to seeing this in the public domain, and I'm pleased to hear that work on addressing the issues has started already.
Indeed it has, Jeff, and thank you for that, and thank you for the support of getting that service user alongside us for this. I think they have found it helpful, and they've been positively responded to the level of transparency around the review. What I would also like to reiterate, and I did say this at the beginning of the review, that once we'd looked at Llandudno Hospital, we would be reviewing the 2 dementia consultant nurses would be doing that assessment across all of our community hospitals, acute hospitals, etc. And that has been ongoing, and clearly that is influencing the structure of the response to both this plan, but their emerging findings from elsewhere.
I think that's good news. Thank you.
Thanks, Joe. Thanks very, very much. There's no hands up, so I'm going to move on, but I don't believe we've got Claire Darlington with us, because the next agenda item is primary care. Joe, are you taking this?
I am, if that's okay, Jackie.
That's fine.
Yeah, Claire's definitely not here. I've just been through the.
That's fine, Joe. Thank you for that.
Okay, yeah, thank you. So just then checking that colleagues can see the presentation material. I'll whip through quite quickly through the slides, if that's okay. But the first bullet point of the 3rd slide just reminds us all that 80% of COVID-19 patients are looked after in the community by family members, with the support of their GP. And whilst of course we've all had to deal with the additional work associated with COVID for general practitioners and the multidisciplinary teams and general dental practitioners, that of course has been on top of their everyday work. And particularly for general dental practitioners, but not exclusively, of course, colleagues will be aware that dentistry is a strong aerosolizing process. So after every patient is treated, each surgery has to be cleaned and left for 20 minutes in order for and ventilated in order for future patients to come through. And of course, that takes a lot of time and a lot of capacity out of dentistry. The 3rd slide just gives a shape with regard to the increase in demand for primary care associated not only with that COVID workload, but more generally, and that is in part a feature of access challenges across the whole healthcare system, with phone calls doubling, with e-consult growth during the pandemic period exponentially growing, and at the same time our colleagues in primary care, in pharmacies, in GP surgeries and so on are and have delivered many flu vaccinations and COVID vaccinations, whilst continuing to provide support for patients who are waiting on outpatient waiting lists. I then would like just to go through some facts and figures with regard to access to primary care on slide 7 now. You'll see that we are with 83.6% of patients are in receipt of appropriate telephony, supporting the needs of callers. Now, one of the things that we've been working on most recently, particularly for the managed practices, and I made a mention of this in the chat earlier on, is to see if we can't improve the range of telephony and communication services available to our managed practices. And we either have or are in process of improving phone systems so that there are more lines in, and that patients are told where they are in the queue, as opposed to ring, 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 ring for a long time, and then the call drops without understanding where you might be in the process. And we're also working with practices to organise their own appointment systems slightly differently, in order to avoid patients in some circumstances feeling that they need to wait and actually having to wait for their urgent appointment for a number of weeks. So still work to do in the space of telephony, even though those numbers are in the 90s, 80s, and of course the 58.8% being the access challenges to which I've just referred. Moving on then quickly to just acknowledge that performance is variable across each of our clusters on slide 10, with good performance particularly on Ynysmon and in Conwy West, but lots of small variation in those numbers, which makes it hard to see those areas of service excellence in this particular presentation. Moving, which is shown in slide 10. On slide 11, I just briefly go through the so what. So what is the board doing about the access challenges that we face? We've most recently engaged with practices in order to understand the demand and capacity detail in each individual practice, not just our managed practices, so we can make sure that we have a really clear understanding of how capacity is developing as COVID has progressed over time. And we are committed, if practices can deliver, to seek to commission additional activity. And that will be an important part of the work that we intend to do, with the Health Board making money available to our clusters for them to identify in our clusters to invest in aspects of transformation improvement. For example, drive-through spirometry, which is a model of care being advocated by Welsh Government, and having been piloted in Powys. The feedback from Powys is that the support for patients with COPD and the appropriate prescribing of asthma inhalers has been significantly increased by a different approach to spirometry. And for those of you who might not know, spirometry is a little cardboard tube. It looks a bit like a toilet roll that you're asked to blow into, often by one of the practice nurses. Again, an aerosolizing generating procedure. You'd be amazed where it goes and which processes are impacted. So ironically, a drive-through in the outside is an interesting approach to spirometry. We're keen to look at that. And one of the side benefits of that is, of course, a small but important contribution to reducing our carbon footprint, because those aerosols do generate quite a bit of puff in more than one way. We're also looking at working with Royal College of General Practitioners in order to support practices to implement, for example, pathways that are relevant to respiratory viruses, which we think might be particularly prevalent over the winter period. Hopefully you'll be aware of some of the good news stories that we're feeding through to try and develop a more strategic approach to communication and engagement on primary care, including talking to the population of North Wales about what the day in the life of a GP actually is. For a GP practitioner, they may receive an online consult which they need to review. That may result in a telephone triage appointment, which may in turn result in a requirement to actually see a patient face to face. That's 3 engagements for one patient. Now, that's not to say that email or phone consults are ineffective. For some conditions, they're absolutely great. For some patients, I love them, but it is itself contributing to additional workload. Then just talking about dentistry on slide 13, which is an area of ongoing concern. Both community dental services, those services that we provide, and general dental services, the high street dentists are able now to continue to start to do aerosol generating procedures, as long as appropriate safety mechanisms are in place. We had around 85,000 GDS contacts during 6 months up to September 21, which is 42% of pre-COVID levels. And if you think about the cleaning processes that we need to put in place between each patient, you can really see the impact of that. Our general dental colleagues and the general dental service that we ourselves provide in rural areas have put additional sessions on for high needs or unregistered patients in order to try and deal with this demand. And of course, we're continuing to work with colleagues around the Dental Academy to work on making sure we're teaching and training dentists, dental nurses, therapists and hygienists into the future. One of the things that I'm really proud of is our improvement or primary and community care academy, which really help improvements in practice. and we're really keen to make sure that that work is continued to focus on important practical issues such as workforce capacity. And I'm able to report that in a number of our traditionally hard to recruit for general practitioner areas, we have started to be successful in recruiting dentists, doctors, GPs to come to North Wales. And as part of that, we're also encouraging the development of innovative multidisciplinary team approaches, including prescribing pharmacists who actually do a really great job with regard to chronic disease management. We work on slide 17 strategically in partnership with a whole range of organisations across Wales and in North Wales. And I would just like to call out the WAST partnership, where we do provide teaching and training opportunities for paramedics who are placed in primary care as part of their paramedic training. And that's a really great joint approach to make sure that paramedics are aware of the kind of challenges in primary care and vice versa. Second to last slide, but last slide that I'll speak on. I spoke about our recent successes in some of our more challenging to recruit areas around GP recruitment. And clearly the announcement of a North Wales Medical and Medical Science School will increase the number of doctors in training in North Wales over time. We do need those doctors kind of right now. And we do need to make sure that we're supporting those doctors at all stages in their careers as newly qualified GPs, as salaried GPs, GP partners, or GPs seeking to work on a locum basis flexibly or on a part-time basis. So we need to make sure we're continuing to think about innovative ways of developing the role of the general practitioner, moving perhaps more into a consulting role, a little like acute care consultants do, with a multidisciplinary team who are under their direction. So some very interesting times for primary care. Final comment, some of our managed practices are really at the cutting edge in terms of multidisciplinary team working and thinking, and are wanting to push the boundaries along the lines as was discussed earlier on around the provision of additional services, which is a model that has been used in England around allowing health boards as a commissioner to commission additional medical services from a general medical practitioner. We're keen to work with our colleagues in Welsh Government to see if we can stretch the envelope around what is called APMS in England, to see to the extent to which we could accommodate more of that work back in primary care. Happy to take any questions. Jackie, not a primary care expert. I don't think I've done Claire's presentation justice, but if there are questions, I'll do my best to answer. Thank you.
Thanks for that, Jo. I appreciate you stepping in. I know Jeff wants to have a word, but before he does, prior to the pandemic, it was quite difficult to attract GPs to North Wales. And during the pandemic, we've seen more and more GPs leaving and not being replaced, and more GP surgeries are advertising. It's a bit of a concern that the Welsh performance list is still applied in Wales. And we wondered whether it might be an idea if we could perhaps push to get this moved, because if you can work in England, why can't you work in Wales?
Well, speaking as someone who's married to a GP who's gone through the pain of the English performers list and the Welsh performers list, and speaking with some of our practices very close to the border in terms of practice managers, where they're aware of colleagues who would be willing to work in Wales with that flexibility. It's a conversation we're always very willing to have. Thank you.
Thanks, Joe. Jeff, do you want to come in?
Yeah. I think it would be remiss if I didn't mention the number of inquiries and comments that we're having about the difficulty in getting an appointment with their GP. The e-consult or video conferencing style consultation is not popular with everybody, but it's popular with a lot of people, and some people enjoy it. It does, of course, free up GP time to see people face to face when they absolutely have to. But none of that is any good if you can't get through and get an appointment either face to face or on e-consult. And we have stories of people ringing at 8 AM for days on end and then getting fed up and going to ED. This is not, I have to add, a North Wales problem in particular. It's happening right across Wales. CHC movement has a meeting every Thursday with the Director of Patient Experience for Welsh Government, and this is the major topic of discussion at the minute. I think what the pandemic has done is laid bare some structural difficulties, and certainly the difficulties in recruiting and retaining GPs. At First Minister's questions a couple of weeks ago, the First Minister said that there are only 8 vacancies for GPs in North Wales. Where to start with that, really? What he'd done apparently was looked in the BMJ and found 8 adverts for GPs in North Wales. That's not how it works. Some of the larger practices might even want 8 new GPs on their own. The new medical school in Bangor, I think, is absolutely the right way forward, but it will be some time before that we start seeing that feed through. In the meantime, I think something that would help very quickly, it wouldn't be the answer, but it would help, it is to deem people who are on the English performers list as suitable to work in North Wales straight away. And then if they stay in North Wales, obviously they get on the performers list. They apply to go on the performers list, but yeah. I know there's other people got their hands up, so I'll let them have a go.
Thanks, Jack. Jill, Joe, do you want to come in, or do you want to take all the questions?
I think Nick might want to come in. I'm always wary of talking about general practice when there's a general practitioner in the room. Over to you, Nick.
It was just to come back, Jeff, on some of your comments, if helpful. So I think there's more than a grain of truth in what you say, and certainly, the impact on some patients is quite significant. I think we all know friends and family who feel frustrated at times. I think the longer term picture that Jo expertly, actually due to her great knowledge of primary care, presented, it gives us a lot of hope. But there are, I think, some difficulties because we've moved a transformation program that would have taken maybe 3 years into kind of 6 to 9 months, haven't we? And then the telephone lines, the technology to support that is still playing catch up. I think one myth I would perhaps dispel is I don't think e-consult or phone necessarily takes less than a face-to-face consultation. And I know I was in a GP practice in the Mould area earlier this week, and they were saying, in fact, that they feel as though the telephone consultations sometimes take more. Because I'm
thinking, Nick, that there's less cleaning and preparation.
No, absolutely. So I think there are some short-term things outlined in the presentation around access. I think the longer-term picture is, looks quite positive. I don't think, though, for this winter we're going to see any change in the performers list regulations, much as I'd welcome them. But it really is quite humbling to see the GPs responding as best they can. And I think the frustrations felt by patients, certainly talking to the GPs, they feel many of them themselves.
Thanks, Nick. Lucy, do you want to come in?
Yes, please, Jackie. Thank you. A couple of things, really. First of all, I think it's, as the presentation actually clearly shows, the activity across primary care during the pandemic has gone up. It's significantly gone up. It has not gone down. It's disheartening for our primary care colleagues to see the message out in the press. And, this isn't North Wales, this is across the UK, that actually primary care is quiet. People, they haven't been open. I've heard it said numerous times, general practice hasn't been open, they have been throughout, and the level of activity has increased. And in terms of recruitment, I think, unfortunately, that kind of rhetoric plays into as well the recruitment difficulties, because people then don't want to come into general practice and train to be general practitioners because they're getting bashed all the time in public, and it really does have a significant impact upon them. It's a shame because they really have stepped up during the pandemic. They've done an amazing job, as much as our frontline staff have. And the second thing I just wanted to raise is about the performers list. So just to say, I actually work over NHS England supporting some of the performers list activity and have been heavily involved previously with the implementation of the performance list regulations over there. We actually have a fast track process in Wales under our regulations. So if someone is on the performance list in England, they can rapidly get onto the one in Wales by shortcutting the process. But it is an absolutely essential safety net, because the general practitioners, all of our primary care contractors actually, they're not employed unless they're part of our managed practices. So the only checks and balances we have in place are actually the performers list regulations. So for me, it's not about not having a performers list, because that is essential for patient safety. It's more about making sure that the administration of the performers list is as efficient and as effective as possible. England are currently going through a consultation process to see whether or not there is appetite to amend their regulations further. Of course, we're behind here in Wales, when ours are 2004 regulations, that England are 2013. But it's just, I think sometimes the emphasis is in the wrong places. It isn't about whether we should have a performance list. It's about how effective and efficient we can make the process. Thank you.
Thanks, Lucy. Jackie, you want to come back?
Yeah, it was just to say that next Tuesday evening, Carol and I are to attend a question time style event at the Plas Menai practice in Lanfechechen. And what the practices are intending to do is to speak to whatever patients want to come along to this event and explain to them what's going on, why it's going on, what the difficulties are. And we think that sort of proactive and positive way of doing things is really to be commended, and it meets the demand people have for greater information and openness as to availability of access to primary care. The other thing we would say, we were out at another meeting with patients in Conway about their practice and some changes that happened there. People were calling for better telephony, to being able to book their GP appointment online, perhaps. They wanted to see technology used to stop the bun fight of ringing at 8 o'clock and not being able to get through. They didn't see why in the age of online everything, it wasn't possible to book an appointment. So perhaps that can be considered in future, I think.
Thanks, Joe.
Thank you.
Joe, do you want to come back?
I don't think so at this stage, Jackie. Thank you.
Right, thanks. And once again, let me reiterate, there are some comments going up in the chat bar, on the chat bar. Yeah. So rather than me read them to you, if you'd like to read those chats, you can see other people's comments. Liz, do you want to be the last question on this subject?
Yeah, this was really about just a inquiry about what efforts are being made to recruit people into the North Wales area, you know, GPs and also specialist practitioners. Given that the property market around this area has suddenly become quite difficult, I'm just wondering about what efforts have made to reach into the training schools to encourage people to consider coming to Wales, as it's such a wonderful area to live in, and whether there's any inducements on offer, that sort of thing. That was just some of the things I was thinking about.
Shall I come back to you on that, Liz? I think there's always inducements, and I was talking to colleagues last week about how we can enact that in a meaningful way, recognising that there are some national framework around that. For me, though, this isn't usually about money. This is about giving people the jobs that they actually want and the lifestyle that they actually want. And I think we've already heard today about how looking at more imaginative ways of offering jobs. As a health board, we're in a unique position, which is much harder in England, to give people matrix jobs that have some time in traditional primary care and some time working in those attached to the ambulance service, working with mountain rescue, working in our ED departments, helping us discharge patients, and really creating portfolio jobs to attract people in. I agree with you. I'm just moving house to North Wales. I think it's an amazing place. I can't see why anybody wouldn't want to come. And in fact, compared with a lot of other places in the country, housing is still remarkably cheap. I think it's yes, money, but I think it's more about sustainability and lifestyle and quality of professional life.
Nick, I had a suggestion a couple of weeks ago that part of the problems was that GPs work part-time, and if Welsh Government reduced their wages, they'd have to work full-time, and that would increase. There is a flaw in that argument.
But yeah, I'm not going to go out with that one, Jeff. You know, we can beg to differ on that one as a recruitment technique.
All right, I'm going to end it there. Thank you all for participating in that one. And it brings us to our last agenda item, which is an update on Stronger Together. And I think we've got Joe and Sue Green.
I think Sue has been kicked out. Oh, yes, she has. She's been kicked out and can't get back in. I think this is this massive updating that's going on right across the NHS.
Right. So I'm afraid, Joe, it's over to you again. Sorry about that.
Don't apologise, Jackie. It's a really important piece of work. And I spoke at previous meetings about the work that I wanted to kick off, and privileged position of being a relatively new chief executive in Betsy, to start to do some work to discuss with our staff what's it like to work here, which helps us pick up some of the priorities that have been identified, of course, as part of the Living Healthier, Staying Well refresh in terms of culture, values, behaviours, communication, and so on. So I'm very, very pleased to be able to just give you a very short update on where we are as an organisation with those pieces of work. And I'll speak to you now about the important aspects of this work before we get into conversations about operating models. So on the third slide, you'll see Bronwyn, Bethan and Wahid. We talk about Bronwyn, who is a fictitious patient, a person who has been living at home, is increasingly frail and has a number of falls and a number of complex chronic chronic conditions, which means she's well known to a number of clinicians across Betsy Cadwallader and her GP, social care, and so on. You get the idea. With Bethan, a younger person who also has challenges that might put her in touch with social care, with education, housing, and of course ourselves. You get the idea. And Wahid, who is a staff member, keen to contribute and make a difference, but sometimes finds the conversations about what he can and can't do, particularly across some of our organisation developed boundaries, a little bit frustrating when he wants to put the patient at the centre of his thinking. So as I speak to our staff, I like to talk about Bronwyn, Bethan and Wahid, patients and staff. These are the people we're here for, the public of North Wales, to deliver excellent patient experience, great clinical outcomes. And in order to do that, although we often talk about the buildings, the acute sites, the hospitals, healthcare is of course a people service delivered by people for people. So I always start by talking about Wahid, Bethan and Bronwyn, because that helps focus the conversations and focus our minds. So when we talk about a Stronger Together piece of work, it's a 3+ year journey. It's a long-term cultural change conversation, which we intend to deliver through 3 phases of discovery, design and delivery. The discovery phase is the conversations that we have with our staff. Always tempting as a new chief executive coming in to say, well, clearly we need to change in this, that or the other way in order to fulfill our aims, our ambitions and our purpose. But one of the things I'm very aware of in Betsy, and it's my way anyway, is that actually staff know a lot, have seen a lot and have a lot to contribute in terms of things they would like to see put right in the way that we work. And you'll see in the diagrammatic representation, there's a strong link between a number of the agenda items we've discussed here in our board to board around living healthier, staying well, a healthier Wales, clinical services strategy, all of which are underpinned by this work. I've talked about discovery, design, delivery, and then into the future. The 5th slide just gives you a sense of the time frames, and we're currently just at the end of our discovery phase. I'll receive feedback. So I've had some feedback already. I'll receive more detailed feedback by the end of the week about the kinds of themes by way of discovery, things we need to do better, things we're already doing really well in Betsy. And that will then be followed by a period of co-design and co-development in terms of the so what next. Again, very easy for me or exec directors or the integrated board to have a view on what we might like to do, but I think it's very important for Betsy, an organisation coming out of special measures into targeted improvement, to take the time and trouble to listen. There are several themes that are already emerging through our discovery phase work and through the individual conversations that I've had since joining as chief executive, and they do number in the many. And that is that we could really improve how we organise and manage the business of the health board. Some of the systems and processes that we put in place in order to try and manage the work we do across our geography, we are being told is getting in the way of effective patient care and good patient experience. And that this work we're talking about in, as the phrase, our operating model. So as we start to think about our operating model, that's how we're organised. You'll know our current operating model is to have acute hospital management units, area team management units, primary care management units, organised informally into clusters, as well as some specialist services, therapy services or imaging services, women's services managed across all of North Wales in what we call a managed clinical network. In discussing our operating model, of course, the options are leave it as it is. We think it's kind of okay. Although the feedback from our engagement work so far is already suggesting that that is maybe not the case. That we should organise, the second option is to organise all of what we do on a place-based, so across in the separate geographies, or we go the other way and say we organise everything across North Wales on a regional basis, or we do a mixture of those two things, or we do something completely different. Something that we haven't yet identified. We're at the moment in conversation with the organisation about which of those options do they feel would respond to the needs of Bethan, Bronwen and Wahid, using a range of design principles which have been developed by frontline staff, the things that are important to our frontline workers. We'll start to think about what our preferred option might be over the next few weeks. And in thinking about our preferred option, we will have in mind those three fictitious individuals and those design principles. And just on the final slide is the timeline, or the tube diagram, as I like to call it, which talks about some of the milestones on the way of our own internal processes. Some of the things that are important to me and are included in the design principles is trying to find ways of making sure we provide consistent outcomes across all of North Wales, and that we empower our clinical colleagues to make as many of the decisions as they possibly can, bearing in mind that many of our day-to-day clinical decisions are already in the hands of our doctors, pharmacists, allied health professionals and nurses already, when their decisions around an admission or a discharge. So of course it's not to say in the work that we're doing that those staff should be, those flexibilities and freedoms should in any way be changed. It feels like it's a good moment to think about how we can organise ourselves to deliver the opportunities given to health organisations in Wales associated with a healthier Wales, that population-based healthcare and prevention, and to think about how we make the most of being an integrated organisation delivering to the strategic framework, which will be our refreshed Living Healthier, Staying Well. Final comment is an observation from England. the English healthcare system is just moving to what they call an integrated care system, which is almost the same as our Welsh system in existence, except that the individual organisations continue to operate separately in a loose federation. We are already an integrated organisation able to influence from self-care all the way to tertiary care. And it's my ambition that we create an operating model that enables our clinicians to effectively do just that. Happy to take any questions, Jackie. Thank you.
Thank you very much, Joe. A whistle-stop tour of Stronger Together. It's quite a big subject. It's not a little strategy. I know it's probably one that's very close to your heart, and I wish you well with it. I'm glad that you managed to get on board and get the staff involved from the beginning in this, because I think to get it successfully delivered, you need the staff behind you, and you need to take their views and what they want, because they have got the frontline observations and skills to actually influence this strategy. So from me, it's quite an interesting concept, and working with Living Healthier, Staying Well, it perhaps rounds the circle. So that's all I've got to say on it. I can't see any hands up, but I'm willing to take questions. It looks as though everybody. Oh, Lucy, you've got your hand up. No,
it's Jeff.
It's Jeff.
It's the mouse.
No,
it's the mouse. The mouse. The mouse is playing. So, thank you very much, Joe, for your contributions today. Mark, do you want to come in? No. Right. I'd like to.
Sorry, Jackie. I was just going to say, well chaired, Jackie. And I think Jeff needs to give you a pay rise.
Yeah, I don't know what a percentage of nothing is.
Happy to double it.
Thank you very much. I'd like to thank everybody that's taken part in the presentations today. I know it's a strain on your time when you're so busy with other things that do normally take more attention than sitting talking to the CHC. But we do appreciate your time, and we value your comments and your input. And it gives us an opportunity to see where you're going and what you're doing, and we can keep our community and our people informed. I know it gives our members an opportunity to ask some of the questions that we sometimes gloss over because we don't know the full answers. So thank you all for attending today. Our next meeting is in April, and we will advise of the date once we've checked diaries, etc. So thank you all very much. And with that, I'd like to say good evening.
Thank you all. Take care now.
Wow.
Au revoir.